Hi, and welcome to today's presentation. My name's Jackie Thelian. I'm a certified coder, certified instructor, and certified chart auditor from two separate certifying bodies. Today, we're going to be talking about the 2021 Evaluation and Management Documentation Guideline changes. And this PowerPoint has been updated to include some examples to help you better understand the definitions, the changes, and we also put in some case studies to show you how that process actually works. So this PowerPoint is current as of today's date, which is January 16th of 2021. Always a reminder, it's your responsibility to stay updated with any changes, and it's the provider's responsibility to determine and submit the appropriate codes. So on that note, let's take a look at our agenda. We're going to do an overview of the changes. Very important are the definitions, because the changes to the definitions and some new definitions actually impact that medical decision-making process. So I'm sure most of you are all well aware by now that the way you choose your level of service only for the outpatient visits this year are based upon your medical decision-making process, or the MDM, or time. So again, as I mentioned, we put in some coding examples, and I do give you a slide at the end with some links where you can go and learn more about it. So these changes took effect on January 1 of this year, and the key thing to notice is that it's only for the outpatient services. So you have to be aware that your E&M services, if they take place in a hospital setting, a skilled nursing facility, emergency department visit, all of these places of service that you see here, you're still going to select your level of service either based upon the 1995 or 1997 documentation guidelines. It's only the outpatient services, your office visit codes, that will change. So it's really important that wherever you're seeing the patient, you remember this is what's going to drive your documentation, and it's also going to drive how you choose that level of service. And this is a nice slide because it shows you the differences between the two. So again, those skilled nursing facilities, rest homes, emergency department, hospital visits, you're still using those three key components, history, physical, and medical decision. When it comes to the outpatient, your office visit services, we can now choose our medical decision-making or time to determine that level of service. Okay, so that's the big change. And the way we now determine our medical decision, or the way we determine time for these outpatient visits, has changed. It's not the same as the 1995 guidelines. So that's what we want to talk about today. And that's what I was referring to when I was mentioning the change in definitions. So by now you're probably thinking, well, if I can choose my level of service based on time or based upon the physical examination, well, what about the history and physical exam? Do I still have to document that? Can I not document it at all? Well, the H&P should always be documented, but the level of that history and physical is left up to that physician or qualified healthcare professional's discretion. And that's always the way it was actually meant to be. If you read the CPT manual, it tells you for your E&M services, it's that nature of the presenting problem that drives that volume of documentation that's going to drive how much history or physical examination needs to be documented. So it's basically going back to that old SOAP note, right? Years ago, when the physicians wrote their note, it was very focused on what the problem was. The examination and the history were focused to that problem, and the key elements were really that medical decision making or that assessment and plan. So one of the first things that we're going to notice is that CPT code 99201 for a new patient in the outpatient setting, which was the lowest level, is now deleted. for 2021. And the coding guidance tells us that you would report 99202. So as we go through the matrix or the MGM process, you're going to see that now 99202 is actually the lowest level of service that you can select for a new patient. So let's start to take a look at the medical decision making and what definitions and changes are going to start to impact the way we do that this year. Some of the key terms here is a problem. And one of the changes that we have when we look at our problems is that you can now count only what's noted at the encounter, right? And it has to be addressed or managed, meaning it's evaluated or treated at the encounter. This is an important concept because oftentimes we see the physicians would cut and paste that patient's entire problem list at the end of that visit or in the assessment and plan, and they may have 5 or 6 diagnoses, but that patient might have only been evaluated and managed for 1 or 2 of those. And we started to find that those who had those E&M calculators would calculate those 6 or 7 problems, but actually it should not have been so because they weren't addressed and managed or evaluated or treated at that encounter. And that includes some consideration of maybe additional testing or some risks or benefits for that patient that requires a little bit more detailed analysis. So hopefully this is going to stop a lot of that cutting and pasting that we saw in those notes. Now here's where we get the first look at how we choose our level of medical decision making. And at first glance, it sort of looks the same to what we're used to with the 95 or 97 guidelines, but there's actually quite a few differences. So first thing we notice, we have our code selection. The level of medical decision making is still based on 2 of the 3 elements. That didn't change. We still have to look at the number and complexity of problems, but notice here comes that terminology, right? We're only counting those problems that are addressed at the encounter. And the amount and complexity of data that needs to be reviewed or analyzed. This is where you're going to see a lot of changes take place for 2021. And of course, we have the risk of complications and or morbidity or mortality of that patient's management. So the number and complexity of problems that are addressed and the risk sections stayed the same with some minimal changes. But when we get to our data elements, this is where you're going to see most of the changes take place. All right, now the first thing we look at the code area is, look at this, your new and established are at the same area. So a straightforward medical decision is going to yield you a level 2, whether that patient is new or established. Now you still have to meet the criteria of a new patient before you can select that new patient visit, meaning that that patient hasn't been seen by a physician of that same group practice specialty or subspecialty within the past 3 years. Okay, so if you meet the criteria for a new patient, you can then go ahead and choose the new patient visit, otherwise it would be established. But the key point here is that new or established, low would be the same, straightforward would be the same. The number and complexity of problems that are addressed, well, straightforward is 1, self-limited or minor problem. Low, when we move up a notch, we have 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. And the AMA actually puts out a very nice listing here. I'm going to give you the link for that later on. But it basically defines, well, what do you mean by a stable chronic illness? What do you mean by acute uncomplicated illness or injury? So they give us the descriptions, and additionally, you get some examples of what would constitute those particular problems. When we move to moderate or a level 4s, Okay. We see that moderate is one or more chronic illness that's exacerbated, or maybe we have some side effects of treatment, or it could be two stable chronic illnesses, maybe the patient's being seen for hypertension and diabetes, or an undiagnosed new problem with an uncertain prognosis. Maybe there's a lump on the breast and we want to do some testing before we make a decision. Or now it could be an acute illness, but with systemic symptoms, or one acute complicated injury. And again, we're going to see when we move over to high, this is where the patient is really severely sick. It's a chronic illness that has a severe exacerbation, or it's that acute chronic illness that's going to pose a threat to life or limb or bodily function. And here the AMA gives us a list. And this is really good because remember on that earlier slide, we had an acute uncomplicated injury. So now we have the definition of what would be a complicated injury. The same with an acute illness we had before, okay? Now it's with systemic symptoms. So these are good grids that kind of give you a good understanding of what they mean with the difference of the problems. How you describe the problem is crucial. So again, that's that first column that's in the matrix that we looked at. And auditors are not clinicians, and sometimes they're not able to determine the status of the problem, right? So what's the difference between that acute uncomplicated or self-limited? And keywords from the physicians in their documentation can actually help with auditing and help to just make things clear. So I give you this slide here, and you can see just from the words, on that grid where this would fall. The problem might be worsening or exacerbated or complicated, or maybe it's stable, resolved, or improving, right? Sometimes they come follow up from an ear infection or follow up from a condition, and that problem has either resolved or it's now stable. So these are kind of keywords that, if they're put in the documentation, helps the auditor to determine the status of those particular conditions. This was one of the great slides that was from the AMA, and it basically puts it into simple terms. So a straightforward problem is something that's self-limited. Usually that problem resolves on its own. Low is something stable, uncomplicated, or a single problem. And moderate can be multiple problems or the patient's significantly ill. And high, obviously that patient is very ill. Okay, so now what we're going to do is we're going to take a look at the amount and complexity of data, because this is where we really see a lot of changes. So straightforward, you're not really looking at any data, you're not ordering any tests. And notice we have some terminology here, right? We have, what is a unique test? A unique test means each CPT code identifies that test. So unlike the 1995 guidelines, where if you're ordering an MRI and a CAT scan and a PET scan, and they all fall into that category of radiology, you would get 1 point. In 2021, if you're ordering the test, and we're going to define what ordering the test means, if you order that, you get credit for each unique test, meaning each of these services were defined by their own CPT code. So if I were to order a PET scan, a CAT scan, and an MRI, each of them having their own unique code, I would get 3 points for ordering those. But notice, to get limited, we have 2 categories that we can choose from. Category 1 refers to tests and documents, and you need 2 bullet points from any of the following. 1 can be a review of prior external notes, again from each unique source, right? So maybe we're looking at hospital records, or maybe we're looking at the patient comes with their chart from a previous provider, right? So these are some sort of external notes, or the review of the results of each unique test, again, meaning it's defined by each CPT code, or the ordering of each unique test. But we need 2 points out of this to meet the criteria for Category 1. Category 2 is an assessment that requires an independent historian. And we're going to talk about that in a little bit more detail as we go on, but an independent historian is someone else other than the patient who needs to give that information. So either of these categories would work just fine to meet the criteria for your level 3 or for low. Okay. When you get to moderate, look at what happens to Category 1. You now have to choose 3 bullet points, but what they did is they took that independent historian from its own Category 2 and added it to Category 1. So for moderate on the data and complexity, it's 3 of these bullet points, or maybe that independent interpretation of test. All right, so that independent interpretation of tests, which we're most familiar with, it's when perhaps, the patient presents to the neurologist and they have their MRI disc, and the neurologist pops that disc in and does their own interpretation. Okay, so that counts as an independent interpretation. Even though they have the report from the radiologist, that neurologist wants to take a look at it himself and make his own determination. Category 3 is the discussion of management or test interpretation. And again, you see with external physician or qualified healthcare professional or appropriate source. So external means you're not discussing these test results with Dr. Smith, who's in your same group practice. They have to be someone who's outside of the practice. An appropriate source will, again, go into more detail in a little bit. But basically, if this is a child, perhaps you need to gather some information on that child's behavior from the teacher. When we move to extensive, okay, look at your Category 1. Now you have to choose 3 of the following from Category 1, but to meet the requirements, you now have to pick 2 categories. So you have to meet the documentation guidelines from 2 categories. So maybe it's Category 1, which are the 3 bullet points, and Category 3, the discussion of management or test interpretation, or maybe it's Category 2 and Category 3, but you would have to meet the requirements of 2 of these 3 categories. So let's go back and talk about tests, right? Remember, we were talking about what defines the test as unique. Well, it's accordance with the code set. So if you have a clinical laboratory panel, like a basic metabolic panel, 80047, even though there are multiple laboratory tests in this panel, because it is identified by one CPT code, you would get credit for 1 point, right? When you are ordering a test, you will get credit for tests that are ordered but not separately reported, right? Key terminology here. So if you're billing for that test, if you're seeing a patient in your office and you're ordering a CBC, but you're going to do it in your office and you're going to bill for it and you're going to get paid for it, that doesn't count as an order. Ordering a test is whatever is being sent out. That's what you will get credit for. And the review of the test result is part of the encounter and not a subsequent encounter. So let's look at an example. A patient comes to the office. They have complaints of sore throat and hoarseness for the past 2 days. They have no relief with over-the-counter medication. The physician documents that appropriate H&P and performs and bills for a rapid strep test, a throat culture, and the disc sensitivity. In this case, each test is identified by its own CPT code, right? We have 3 tests. We have the rapid strep, we have the throat culture, and the disc sensitivity. But since all 3 tests are being separately reported, meaning that they're done in the office, that physician does not get credit under the data element on the MDM matrix. Now let's flip the coin. We have the same patient, same problem, but here the physician orders a throat culture and disc sensitivity that's being sent out to the laboratory. So since the tests are being billed by the laboratory, the physician will get credit for ordering those 2 separate unique tests. Okay, so some other key terminology. Remember we were talking on the matrix, right? You get credit for review of prior external notes. And it means just that. Maybe that patient is coming in with notes from other healthcare organizations, the hospital, and an external physician or QHP is someone who is not in that same group practice. And an example of this is a patient who presents with multiple pages of medical history, test results from their primary care physician who is seeing either a new PCP or seeing a specialist, and that specialist will have to review that information. The same with the discussion or management of test interpretation. Okay, and this again is with an external physician or QHP. An appropriate source, it's not just sometimes other physicians, right, that provider has to speak to. Maybe they have to work with the pharmacist, and they're calling up the pharmacist to make sure they get that medication right for that patient. Or maybe it's a lawyer, or maybe it's a case manager or a teacher, right? But this does not include discussion with family or any informal caregivers. Independent interpretation is just that. That's when that doctor is doing their own interpretation of a test that may have been already reviewed by a radiologist, but they want to put that image or that film in their own computer and make their own interpretation. The good news is you do not have to do a formal report to get credit for this, but simply documenting what your findings are in that patient's note is sufficient. Okay, what's an independent historian? Well, we saw that on the grid as well. You get credit for this, right? So this could be a parent, a guardian, a surrogate, a spouse. And this is someone who's giving additional history provided by that patient who's not able to maybe give a complete or reliable history. You think of sometimes people have dementia or they're too young to give a complete history about that problem, illness, or injury. And, we had a question that came up, which was a good question. If the person doesn't speak English and the history is taken from a surrogate, does that qualify as an independent historian? And the answer is no, that's really a translation service. It's not by an independent historian. In this case, that person is just relaying the information in English, but the patient themselves is able to give a good history. Social determinants of health is a new concept this year, and it's an important one because this is going to fall under moderate risk. And keep in mind that risk is just one of those 3 components. You need 2 of the 3 components. So just having social determinants in and of itself doesn't make it moderate. So a lot of people, particularly now with the pandemic, are having some economic and social issues. This may include things like food or housing insecurity. Either of these definitely has a negative impact on that patient's health. So if that is documented, it does fall under the moderate risk category. Which brings us to our risk category now. So we went over everything in the data elements column. And when we look at risk, again, anything that is straightforward is minimal risk. And low risk, again, things like over-the-counter medication, right? There's always some risk when you take an over-the-counter medication, but it's typically a low risk. Your moderate risk, your prescription medication, a lot of this didn't change from the 95 guidelines. The decision regarding minor surgery that has identified risk factors for the patient, an elective major surgery without risk factors. And here you see falling under the category of risk is that diagnosis or treatment that significantly is limited by social determinants of health. When we get to the high risk column, this really didn't change. Someone who needs emergency major surgery, the decision for hospitalization, elective major surgery that has some identified risk factors, and so on. Okay, so now that we have all of the information on the three columns, again, we want to stress it is the best 2 out of 3. So in this example here, the patient came in, they have one acute uncomplicated illness or injury. The doctor did not do any testing, didn't look at any data, but maybe they gave them some over-the-counter medication, so they're at low risk. The best 2 out of 3. If this were a new patient, it would be a 99203. Established patient is 99213. Okay, so let's look at a case study. Mrs. Smith presents for a follow-up of diabetes and hypertension. The doctor performs the appropriate H&P and determines that the patient's conditions are both stable. The patient is going to continue with their current medications, their prescription medication, and they're going to follow up in 5 to 6 weeks. So in this case, the patient has 2 or more stable chronic illnesses. We did not order any tests. We did not review any data, but we are keeping this patient and we're managing them on their prescription drug medication. Since it's the best 2 out of 3, this would be a 99204 if it were a new patient, or a 99212 for established. Case study 2. The patient presents with complaints of sneezing and runny nose due to seasonal allergies. The physician performs an appropriate H&P. The diagnosis is documented as allergic rhinitis, and the patient's instructed to use some Claritin, which is over-the-counter medication. So they're going to continue the OTC, and then they're going to return only if that problem persists. So here we see that this is an acute, uncomplicated illness or injury. We're not ordering any tests or looking at any data, but the patient's at low risk. The best 2 out of 3. This would make it a 99203 for a new patient, or a 99213 for established. Okay, let's look at one more. Patient presents with complaints of fatigue and inability to get a good night's sleep. The physician performs an appropriate H&P, and the physician orders a comprehensive metabolic panel that consists of multiple laboratory tests, and they order a sleep study. The patient is instructed to continue to try the over-the-counter Unisom and then to return after the sleep study has been completed. So in this case, we have one undiagnosed new problem with an uncertain prognosis. So we're ordering some tests. Maybe the patient has chronic fatigue syndrome, and that's causing the inability to sleep, or maybe the patient has sleep apnea that's causing the fatigue. So this provider orders 2 tests, right? They order the comprehensive metabolic panel and the sleep study. Now, even though the 80053, that comprehensive metabolic panel, includes about 14 laboratory tests, they only get credit for 1 because it's identified by 1 CPT code. And because both of these tests are sent out, they're ordered, they're not done in the provider's practice, he'll get credit for ordering each of these 2 unique tests, meeting category 1, so the data elements are low. And his decision for this patient was to give him some over-the-counter medication and then to come back when those tests are done so he can make that decision. It's the best 2 out of 3. So this would be a 99203 if it were a new patient, or a 99213 if it was established. So I think by now you kind of get the hang of it, and we're going to move on, and we're going to talk about how we choose our level of service based upon time, because that terminology and the way we choose our level of service based on time has changed as well. Again, making sure we understand that what we're talking about now, it only applies to the outpatient services, your 99202 to 99215. And for your other services, your skilled nursing facility, the hospital, you want to make sure that you're still using the time element as defined in the 95 or 97 documentation guidelines. So one of the key things we note is very interesting this year. When we talk about total time, it's the total time on the date of the encounter, not just what happens during that face-to-face with the patient, because now it also includes some non-face-to-face service time. And when we talk about time, it still has to be with that qualified healthcare professional or physician. It is not clinical staff. So any of this that is done by the clinical staff cannot be included in the time element for the date of the encounter. So what's included in time? Well, preparing to see the patient. So sometimes doctors spend time bringing up that patient's information before the patient walks into the room, so they're familiar with what's going on, or maybe they want to review the test results so they can, better advise the patient. Obtaining or reviewing separately obtained history. You now get credit for your time to perform your H&P. The counseling and education for patient and family member. Ordering medications, tests, or procedures only if this is done by that physician or QHP, not if you're giving this to your clinical staff to do. Referring and communicating with other healthcare professionals, look, when not separately reported, right? Independently interpreting results when not separately reported, and coordination of care when not separately reported. So particularly primary care, they do a lot of this functionality when they're reporting transitional care management or chronic care management. So if you're separately reporting any of these services, you can't count it again in that E&M. But time that you can include is the time that you spend documenting clinical information in the electronic or healthcare record. So if you're thinking this is sounding really cool and pretty good, be careful what you wish for, because there's only 24 hours in a day, and the time elements for these codes have changed. They have been increased in some cases. And if a provider, any provider, chooses to determine their level of service for all their visits based on time, the carriers will come in and do a time study. So use it when it's appropriate. You can still make more of your E&Ms based on the medical decision making as opposed to reporting all of them on time. So let's take a look at how the time elements have changed. Okay, so here's what our time is now. We notice 99201 is deleted, right? And they basically didn't change too much. Your 99202 now, if you have at least 15 minutes, you can report it. So that went down. And all the rest of them, your 3s, your 4s, and 5s, you still have that threshold of 30 to 44 minutes, or 45 to 59, or 60 to 74. So not so much on the changes there, but when we move to established patients, look at what happens. It's like a knee-jerk reaction. We're also used to knowing that 99213 is 15 minutes. Well, now it's 20 to 29, right? So there's a big jump there. And your 99214 that we were all familiar with for 25 minutes is now 30 to 39 minutes. So when you look at these changes in the time elements for your established patients, you're still probably better off doing it on the MDM, unless, of course, you're doing a lot of those functions that we saw in the previous slides that do take up a lot of time, because it is total time on the day of the encounter, not just the total visit time. So things to think about. So here's an example. We have an established patient. They come in with side effects from prescription medication. Dr. A documents the appropriate H&P, notes that the patient has multiple allergies to various medications, and does some extensive research and discussion with the pharmacist to determine that appropriate medication change for the patient. And a total of 35 minutes is spent seeing the patient, researching the medications, talking to the pharmacist, and then finally documenting that information in the encounter. So based on time for this established patient, 35 minutes is equivalent to your 99214 visit. We also have this year 2 new prolonged attendance codes. So the government realized that, that 30 minutes, that extra 30 minutes time is kind of a hard threshold to reach. So what they do is they now give you a prolonged office visit code, or that you can add on to your highest level of E&M service. So again, you can only use the 99417 once you pass the threshold of your 99205 or 99215. And notice it's for each 15 minutes of total time that's over and above that highest level of E&M. For Medicare, the code is a HCPT code. It's G2212. And again, you first have to reach that highest level of service for either new or established before you can report it. And this is, these are great links where you can go and you can download more information from the AMA. Stay updated with this information always to make sure that you have the most up-to-date information. And we do have a little bit of good news here. The conversion factor for 2021 did not decrease. They actually increased it, so you would see a nice bump up on some of the E&M codes. So national reimbursement, for example, your 99214 is in line for a 12% pay gain, and you're looking at approximately $123.48 per encounter. And for established E&M of 99213, that goes up to a 21% boost, pushing that up to $92.47, again, at a national level. So I thank you for attending. I hope you found it informational, and happy coding with the new guidelines. I think we'll all find them very interesting and beneficial.